So I'm going to let my colleagues up here introduce ourselves, and then we'll start talking, and then we'll open up for questions in a little bit.
Hello, everyone. My name is Susan Caputo. I am a licensed social worker. I hold a master's degree in social work from Rutgers, and I have a certificate in aging. I am the director of the ESCOPE program, which we'll talk about in detail in a few minutes, but we are a grant-funded program, as discussed by Trinitas Regional Medical Center and RWJ. With that being said, I am going to pass it over now.
Hi, my name is Walter Rhodes. I'm a DO. I work for Dr. Scheinthal. He's my boss. I'm the assistant chair, vice chair at Rowan as well. But for the last 4 years, I have been part-time working with Rowan, and I've been the medical director for Oaks Integrated Care. So I oversee different programs in Oaks, and one of the programs that I oversee is the screening center in Camden County.
Good morning, everybody. Mike Damico. I'm a licensed clinical social worker. I'm vice president at Oaks Integrated Care. I, too, graduated from Rutgers. Maybe we were in the same class. I don't even know. I also adjunct at Rutgers now in the social work program. Like I said, I'm a vice president at Oaks. I oversee our ambulatory and acute care services for the organization. Just for context, Oaks, we serve really, I think about 14 counties in the state. So we provide addictions treatment services, outpatient ambulatory care, crisis services in Camden County. We're also on the forefront of implementing models such as the Certified Community Behavioral Health Clinic, which I'll probably talk about a little bit more later, which is a really exciting new model of integrated care that has been implemented over the past 5 years nationally. And for the first time in a very long time, actually heard President Biden speak about the CCBHC and behavioral health in his State of the Union address last month, which is really exciting and really, I think, shows where behavioral health, mental health is in terms of the landscape and the priorities of the nation. So that's who I am, and I'll pass the mic back over to Walt.
Well, why don't you? So Mike, keep the mic. So, you mentioned the community behavioral health model, but I'm hearing patients saying that there are like mental health urgent care centers. So why would someone go to a crisis center, and how does that differ from the urgent care center, and what is the urgent care center?
Yeah, so the urgent care model, it's known as Early Intervention Screening and Support Services in New Jersey. And maybe this is a healthcare general thing, but we're so acronym heavy. So it's known as EISS, but we brand it as Urgent Care Mental Health because that is in fact what it is. Bringing parity to the urgent care concept on the physical health side, to the behavioral health side. So EISS, or I'll just refer to it as Urgent Care Mental Health, is a model that has existed in the state for well over a decade. But actually, just recently, the state has finally awarded the rest of the urgent care grants for the remaining counties in the state. So at this point, I think probably in June, all 21 counties in New Jersey will have an urgent care mental health program somewhere in the county operated by a behavioral health organization or a hospital partner. So the concept of the urgent care mental health program is similar to the concept of urgent care in the physical health space, in that it's meant as a diversionary to get people to go to receive care, initiate care when they're experiencing an acute or subacute sort of a crisis, in lieu of going to the emergency room or crisis screening. As we'll talk about in a little bit, the role of crisis is really to make sure that we're screening individuals for inpatient, care if it's necessary, and making sure that we're stabilizing them if they are in fact a danger to self or others. Whereas the role of the urgent care really is more to initiate treatment. And so we hope that as folks are walking into the clinic and into the facility, that we're able to stabilize them immediately and begin care and provide them with care for up to 8 to 10 weeks while we work with them to find more sustainable services within the community. So it really has been a lifeline in diverting people from ED and avoiding overutilization and burden on the emergency department, but really improving the client experience of care, right? In that it's much more beneficial for somebody to go to an urgent care clinic to have care initiated immediately than it is to go to an emergency department, be given medication for a day or two, only to be returned back to the community. And we also know this is one of the other benefits of urgent care mental health is the transition back to community. Even for folks that are going into the emergency department for physical health care needs, making sure that once those things are triaged and stabilized, that they're linked and connected with their primary or a specialist that can follow up with them on what they were seen at in the emergency department. On the behavioral health side, we see a lot of folks that drop off in terms of their connection and linkage to aftercare after they've been seen at the emergency department. So one of the benefits with urgent care is that we're not just stabilizing the person, but we're providing them with treatment, and then we're making sure that they have access to long-term care in the community to prevent, decompensation and further crisis episodes.
So Mike, sticking with that for a second, because I just noticed right in the front row is one of my emergency department physician partners, Dr. Tomasco, who's at the Stratford ED, actually. You're very familiar with that ED. So if any of the ED physicians in the audience get a patient in who they think needs mental health care, can they discharge them to a mental health urgent care center, or do they have to wait for screening to come into the emergency room? And do they make a phone call and set an appointment, or is it walk-in? What happens?
Yeah. So happen a couple different ways, but absolutely we have folks that are discharged from the EDs all the time. So the goal is to get them from the ED over to urgent care. You can send them to walk in. It's usually helpful when we have either a physician or the charge nurse or somebody call over, give a little bit of context, provide a little bit of information. But the individual doesn't have to be screened necessarily to go over to urgent care mental health. It could also be somebody who's coming in with some other kind of physical health issue, and you all are seeing that there's a secondary psychiatric diagnosis that they would require treatment for, and that's again somebody that you should absolutely send over to one of your local urgent care centers. And for those that are in a county other than the ones that Oak serves, which is Cumberland and Camden, with respect to urgent care, I think that developing those partnerships and that dialogue and developing those workflows is really critical. I know we've seen that a lot in Cumberland County and Camden County, where EDs are very much aware of what we offer. Once they're stabilizing somebody and they're making sure that they're medically cleared to leave and they don't have an acute psychiatric issue, that they're discharging them and sending them right over to us, and then calling us and providing us with some context and information, so we understand, hey, maybe there was some medication y'all gave them. So as we're doing our psychiatric evaluation and prescribing medications, we're aware of what those things might be.
Great. So, Dr. Rhodes, I hear, in passing and from primary care colleagues, I sent the patient to crisis and then they get sent home. So why does that happen?
Well, the real goal of the crisis center is, like Mike had said, is to stabilize the patient, stabilize the person, and make sure that they get the appropriate treatment. So we don't always, the crisis center doesn't always feel that someone may necessarily need to be hospitalized to get the appropriate treatment. Like Mike had just said, the EISS can help be very stabilized. So I mean, the great thing about that program is that, because I've done it in the past as well, we get a patient coming in that day, the social worker sees the patient, and then the psychiatrist will see the patient that very same day. So that's can decrease the crisis right away without having to hospitalize the patient. As we know, in New Jersey certainly, but across the nation, there's not enough beds, inpatient beds. So having the patient wait in the ED for a few days, a week, is very problematic for the ED, as he's shaking his head. And we'd rather stabilize the patient not in the ED as opposed to admitting them. So that's one of the reasons one of the answers to your question. The other answer is that in New Jersey, part of the screening's job is to make sure that there is, the person's mental illness rises to the point where it's an imminent risk to self or others. And that's what the screener's job is, as well as the psychiatrist, to make sure that we're not violating their civil rights and forcing them to be hospitalized.
So does everyone who go to crisis, you said everyone at mental health will see, at urgent mental health care will see a psychiatrist. Is that what happens in the crisis center as well?
No, not necessarily.
Really? So it sounds like the urgent mental health walk-in center, you're going to get more holistic, rounded care than in the
Absolutely.
crisis center. So who do they see in the crisis center?
So in the crisis center, they'll see the crisis screener. That's
Which
actually,
is?
which is the social worker. I don't, yeah.
Yeah, so New Jersey is definitely different than some of the other states in terms of how the crisis works. I know there was a physician that we work with at one of the hospitals who comes from Pennsylvania, which has a much different setup. So in New Jersey, the process is that if an individual is in imminent risk and we're considering that they go inpatient involuntarily to a hospital, they actually need to be assessed and evaluated by a certified screener. The certification happens through the state of New Jersey. Those individuals have certain credentials. They're not doctors. They're typically social workers and counselors and the like. So once they do their evaluation and they make their determination, then it's also up to a physician to do their evaluation and agree with that. So as Walt mentioned, it's very heavily focused on patient rights. And making sure that, as we're making the determination to involuntarily commit somebody, you're really taking away their civil liberties and, putting them in a hospital in an institutional setting. So, the state takes that very seriously and has a system of checks and balances to ensure that we're not making, decisions in silos, but we're considering, different vantage points and viewpoints and making that ultimate decision to involuntarily commit somebody or discharge them back into the community.
So, full disclosure, I've worked in crisis centers, and I know at times nursing homes like send patients in and then they're very angry that they're being sent back, or where they'll refuse to take them back, which is a whole nightmare in terms of their license. So, Susan, you said you're from this ESCO program. What can you tell us about that?
Yes, so I am from ESCOPE, which is statewide clinical outreach program for the elderly. We serve nursing facilities in the whole state of New Jersey. We are a free program, and we serve 55 and older. Any client that presents to the screening center can automatically be referred to us by your nursing facility or the screening center themselves. With that being said, also, we would like to divert that client from presenting to the screening center, though. If it is an unnecessary referral, meaning that they will not meet the criteria for commitment, we would like to come out and divert them before sending the client to the screening center. With that being said, if a client states they want to commit suicide and it's more or less a passive death wish rather than a suicidal statement, we would like to come out and intervene before you send them to the screening center. We use non-pharmacological recommendations. We are a very unique program, which is great because we're a free program, but we also have everyone on our team. We have general psychiatrists, we have an advanced practitioner nurse, we have RNs, and we have licensed social workers and LPCs. So we have a very big team, and it really covers all our bases. Besides the recommendations that we can offer educational training for your staff. So with that being said, there was a question earlier, what can I do when the nursing facility calls me about all the behaviors that keep occurring, but I know they are not to be treated with geriatric medication? With that being said, we can come out and provide that training if you don't have the time. Our staff is very equipped. We have trainings, full list of paper, and that does not limit us. We also provide regional trainings on very heavy topics in the community this year, and then we hold a conference. So we have a bulk of services to offer.
So, Walt, you mentioned imminent risk. So what is the commitment? Like, if someone's going to go in voluntarily, like if I come into the crisis center or I go into an emergency room and I say to Wayne, who I'm friendly with, Wayne, I want an MRI. Wayne doesn't go, okay, Steve, I'll give you an MRI. Wayne does a full assessment. So if a patient comes in or a doctor sends someone into crisis and they say they want to be admitted, do they just get admitted? Is it like the pass-through center, or what happens?
No, they just don't get admitted, right? Like I had said earlier, even if they're, well, certainly if they want to get admitted, there's a criteria that has to be met for inpatient admission. And really, it does, again, for a short-term care facility, it's that there is still a crisis, an emergency crisis going on right now that can't be dealt with in the outpatient setting. So someone that is, imminently suicidal wants to get admitted. I mean, that's more of an emergency. They have a plan. They have a very intricate plan. That's an emergency that someone would need to be in. But someone that is, like you mentioned earlier, passively suicidal or just having those thoughts, they can certainly be treated outside of the hospital in multiple different programs.
So, it would seem to me in all my nursing home and assisted living work, if someone comes in who's got pretty advanced dementia, they don't necessarily know what they're talking about, right? There's not, correct. It seems imminent to the staff, but it's really the patient may not understand what they're saying. They say, I've seen it happen, the family's there and they say, if you leave me here, I'm going to kill myself. And then everyone gets up in arms, but the family leaves and then they're like playing bingo and they're going to dinner and they're, watching movies. So, is that crisis or is that SCOPE?
So that would be SCOPE.
Correct. And we would go out and we would do a face-to-face assessment. We can be out within 2 hours. The other day, I was at a facility within 10 minutes after the call. Our response time is very quick. We will respond at max within the 24 hours. We do a face-to-face. After the face-to-face, we do leave the facility with written recommendations and paperwork. So as soon as we walk out the door, you already have how you're starting to treat this client. With that, we then provide a follow-up, and we go back, we consult with our neuropsychiatrist weekly, and we do case reviews weekly.
So where are the offices located that you can get there in 2 hours? That's,
So our offices are statewide, as I discussed. With that, they are in Parsippany, Cranford, Wall, New Jersey, and Stratford.
Great. Well, that's cool. Mike, you mentioned this community behavioral health model that President Biden mentioned. Do you mind elaborating on that? Because I don't think most people here.
Sure. So the Certified Community Behavioral Health Clinic, I guess maybe the best way I can sort of describe the concept of it is it's similar to the FQHC, or Federally Qualified Health Clinics concept that was a designation made by the federal government. But this is, the emphasis here is on the behavioral health side. So the CCBHC was really born out of legislation back in 2015, and that legislation then set the stage for a Medicaid demonstration project that was supported by SAMHSA and was funded, again, by as a Medicaid demonstration project under legislation at the federal level. And it started in 2017 in 7 states in the country. New Jersey was one of the first states to be involved, and Oaks Integrated Care was one of the first of about 70 organizations throughout the country to implement the model. So the CCBHC, as we call it, has been gaining a lot of momentum over the past 5 years. It provides wraparound care and a very broad continuum of services. So it provides everything from ambulatory outpatient care to care management in the community, peer services, psychiatric rehabilitation, so things like supportive employment, supported housing, addictions treatment, including medication-assisted treatment, so MAT, as well as a whole host of other things. One of the main emphasis of the program is access to care. Recognizing that access to care and has been just such a huge challenge for behavioral health over the past few years, this model and the way that it was developed was really designed to promote and increase access to care. And it also puts our behavioral health services on some of the same level in terms of our outcomes and what we're looking at in terms of performance and so on as other healthcare facilities. So for the first time, behavioral health is being measured using HEDIS measures. So this project was really innovative in that way on the behavioral health side as well. But the other concept beyond the access is reducing silos to care. So making sure that as folks are coming into a facility, that we are working together, there's care coordination and collaboration, and we're not having people sending them all over the county for different services, but rather operating as a hub and spoke sort of a model to make sure that the person's care is centralized, and that the care within that facility or with partner facilities is coordinated and collaborative. So it's again, I was mentioning that it was mentioned in President Biden's address. So it's a Medicaid demonstration project. In 2017, there were some expansion grants that SAMHSA had budgeted for since then. But the demo is really the gold standard of what we hope certified community behavioral health clinics will be into the future. The other thing that it brings with it is a cost-based reimbursement model. So behavioral health has also been challenged by typically or traditionally lower rates, has kind of struggled in that way. And so for the first time, there's now a model of care that is cost-based in terms of its reimbursement and payment methodology, and really allows the organizations that are providing the care flexibility to do a lot of different new and innovative things, again, similar to what you see on the federally qualified health care centers. And there also is an emphasis on primary care. So as an example, in our CCBHC clinic in Mercer County that was a demonstration project, we actually worked with our FQHC partner in the county, Henry J. Austin, and they were offering some satellite primary care services on our site. And through that partnership, we decided that, let's take this one step further. And we actually built out an ambulatory care facility within our behavioral health facility, so which eventually became licensed so that Henry J. Austin's eligible to bill and provide services directly in our facility. So now, and still could be the case, but at the time it was the first licensed ambulatory care clinic within a behavioral health clinic in the state of New Jersey. So it was pretty innovative in that way. And essentially the concept was you walk in, you're getting services, behavioral health care services, and if you have an urgent need or if you want to have a routine checkup with your primary, you walk down the hallway and you go into the Henry J. Austin suite and receive care from them. So it was a really cool concept, and something that, again, would not have really been possible without this whole CCBHC sort of framework.
Great. So for all three of you, what happens if the decision from mental health urgent care, from crisis, from SCOPE, the primary physician or the family disagrees with the determination? Is there a recourse? Is there a second look? Is it, what happens there?
Well, I can say in screening, if a screener sees the patient and they don't feel admission is needed, then if there's a conflict with anyone, family, the emergency room physician, the primary care, then that's where the psychiatrist would certainly evaluate the patient at that point in time. If there's still a conflict at that point in time, then actually the medical director of the screening center would get involved, so that would be me. So there would be another level, so to speak.
So if a physician, one of our colleagues here referred someone into screening, should they get a call from the screener, or is that typically not what happens, that a call's not a routine part of that?
Well, I can't say that the call is normally routine at that point in time. What I can say, though, from a screening point of view, is that getting as much information is very helpful. Just had a patient I just had a patient from one of my programs that was just admitted, and I myself called the screening center, told them what was going on, my concerns and whatnot, and it was helpful to move the patient along and get his treatment.
Great. What about Esco?
So ESCOPE, if someone does not agree with us, we typically don't work with the family. The facility is our client, but there is no limit to our service. So we will go out, we can reassess. We always review with our geropsychiatrist. And if it's a challenging case and we're looking for additional recommendations, we do have a program called ECHO, and we can present this case on ECHO, which is on telehealth. And at that point, we have an additional geropsychiatrist review the medications, the recommendations that were given, the case, the behavior observation at this time, and we can also offer a doc-to-doc at that point.
Great.
I'll just add one thing I think that's important just to sort of emphasize what Walt was saying is the discussion with family and collateral. So, a lot of times folks may be presenting differently when they get to the crisis unit than they might have been in the community. And so getting different sources of information, is really critical in terms of formulating the decision about the assessment and the decision about involuntary commitment.
So one of the things I've run into a lot, and I know, Mike, you and I have talked about this, Walt and I have talked about this, not so much with nursing home patients, but there's secondary gain, right? Families want someone placed, they want them out of the house, the person's homeless, they're not fully disclosing that they're homeless. How do you sift through the secondary gain issues? Because I know for me those become very challenging because you can hear two very, very different situations. And, I don't know that there's a right answer, but I think the difference in perspective might be interesting.
Yeah, and it happens with kids a lot too. I think that's where we see it a lot in terms of can't manage the behavior, we don't have the resources to manage the behavior. A lot of times some of the resources are intervening with the family as well. And so in a lot of these situations where we see that the family might be burdened, there's resources available, for the family. But just to back up in terms of the assessment, we do need to take into consideration, what the person's living environment is. And crisis really does have a limited capacity in terms of, what it can do kind of in long term in terms of recommending care and so on after the fact. But working with the family to set up and establish resources if the person's not going to be committed for aftercare, right? So identifying, the different social determinant of health kinds of needs that the individual might have and making sure that we're making appropriate recommendations to address those things. So there's services to address homelessness, there's services to address environmental resource needs, but then at the same time, what I was alluding to earlier was working with the family and connecting them with things, services like our family support services, right, which offer different groups and individual work to family members who are caring for an individual with, a mental health or substance use diagnosis. Or NAMI is another good resource for family members to be able to discuss and meet with peers and other family members who are experiencing some of the same, experiencing some of the same challenges. And I think that helps to give families some perspective, it helps to give them some hope, and it helps to include them in the treatment process as well, which I think is really critical. So I think giving family resources, helping them in developing the care plan and involving them in the process and empowering them. I think when families don't feel empowered, they also feel this, they need to be committed. There's nothing I really can do. But when we start to talk to them about resources in the community and how we can connect them, I think it builds that trust, it builds that empowerment, and helps them to buy into a plan. Because really our goal is the least restrictive means necessary. We don't want to commit somebody unless it's otherwise absolutely necessary. And so if we can come up with a care plan that keeps them in the community, that's the goal.
Great. Well, how do you handle that? Because from the physician standpoint, while we
I
all
mean, from the
align?
physician standpoint, I agree with you. There's never necessarily a right answer to that. But I can say just yesterday, I had a patient that very similar presentation. They weren't necessarily in the crisis center, but the family was demanding one thing that really was not appropriate for the patient, and getting actually what other than trying to talk with the family and trying to get everyone on the same plan. One of the things we did recommend is the family support service program that Oaks does have, to give the family as much support as they can during these trying times until the patient was able to formulate a better plan, healthy choices, a healthy choice.
So although we haven't spoke about it, I feel like the nursing homes do play a part in this also, whether they are sending a client to screening, because unfortunately they are short-staffed at this time. We get some clients that are wandering the unit, and they will see that as a problematic behavior. We like to look in, why are they wandering? In addition to that, sometimes families are having a difficult time with dealing with the process of, unfortunately, their parents are now aging and they have become the parent in a different aspect. With that, it is difficult to sometimes look at your parent with dementia-related behaviors, and the person they once knew, unfortunately, is not acting like that anymore. So we then have to also sympathize with the family and come up with recommendations that we are in the best interest for the dementia-related behaviors that are taking place.
You guys okay if we open it up for questions? So, I don't know if we covered everything, probably not, but what questions, it's a unique opportunity to hear, multiple aspects of the state's mental health safety net, which you all intersect for your patients.
So I'm from Gloucester County. So can we go to Oaks in Camden County or Cumberland County with my patients? How do we access care since you're not in our county?
Sure. So we partner a lot with Ascenda, who is they're actually the screening center in Gloucester County. So they were actually awarded the Gloucester County Urgent Care Mental Health, or EISS program. But the beautiful thing about urgent care is that it does not limit by geographic area. So I know we had worked with Rowan University too on some of their students in Gloucester County, and a lot of them were going to Cumberland or Camden County, depending, because Gloucester at that point didn't have it. We get people from Pennsylvania, we get people from Delaware. So, but yeah, there's really no geographic limitations.
Ascenda, is it ASCNDA?
Oh, yes, ACENDA. It used to be Robin's Nest, Cape Counseling, and North Point? New Point Behavioral Health.
Hello. I'm just going to relate a funny anecdote. About 15 years ago, I was a doctor in the Appalachian Mountains, and the deputy sheriff came to my office, and he told me one of my patients was threatening to kill me and that I should lay low for a while. I don't know how to lay low. I don't know what that means. And about 5 days later, my front office started screaming because they saw him walking to the front door. They locked the front door, the whole office cleared out the back, and then the patient came up and tried to open the door. So I walked up to the door and I opened it. And I said, "Hi, can I help you?" And he said, "Hi, Doc, I just want to let you know that I'm not mad with you. That was just a way for me to get into the hospital." So you either had to be suicidal or homicidal. He picked homicidal. So it was a swing and a miss. I was okay, but I just want to let you know that it was a challenge to open the front door for him. Thank you.
I think that's the challenge we face, right? Is when I was talking about secondary gain.
Yeah, we're It's funny you say that because we work with the Camden Coalition for Healthcare Providers in Camden County, and one of the things we were looking at were high utilizers of ED service, and we were working with some of the docs and so on, and looking at some Z-code diagnoses, and to really identify some of the social determinant kinds of issues that folks are walking in with. And what we found was that a lot of people were accessing the ED and reporting, maybe not that they were homicidal or suicidal, although it does happen, but presenting with other issues and concerns. But really, the underlying need was much different than any physical or even behavioral health issue. It was more about some environmental and concrete resource needs that individual had. And so, it is trying to kind of sift through that and get to the core and the root of really what the need is. And I think at times, people aren't even as conscious of, why they might be doing it, right? And so it's our job to sort of play detective and figure out, what is sort of at the core of what this person really needs.
And I think ESCOPE can piggyback off of that because we do see the residents that are in the nursing home and their day is spent in the nursing home. I mean, we saw it during the pandemic. They weren't even allowed out of their rooms. And during that time, an ambulance ride to the screening center was just that little bit of satisfaction.
And it's the same thing with the group homes that we dealt with in residential programs, and during the lockdown and during pandemic. And even now, Don't Like My Day program. I've been there every day, or I'm sitting in my room on telehealth. It definitely, yeah.
So trip to screening as a field trip outing.
I think there's probably a well-known guy at Crisis, and he comes in. I know they give him a sandwich and a cup of coffee, and he's not homicidal or suicidal anymore, and he's happy to go back to his group home and everything like that. So.
Yeah.
Hi, I have a lot of Medicaid, right? And I do use Integrated Oaks, but I don't want to feel like I'm using you obsessively because they kind of crash and burn most of the time. So I feel like I need your support system and more knowledge on what you use, because I feel like it's that secondary visit a lot of times that is hard to do the follow-up and try and get a better diagnosis for the patient.
Oh, definitely. That I think does the that initial appointment is one thing, but the engagement, that second appointment within 14 or 30 days is really the key. And I know Dr. Panenti, who I think is talking later in Rowan. Yep. That's what he says too. Is our primary job is to make sure the person comes back for the second visit. That's our job at the first visit, right? To make sure that they come back. But I'm more than happy anybody who's in our territory to talk more and meet and figure out. There's sometimes unique challenges that certain facilities or clinics have, and we welcome partnerships and establishing different specific workflows and so on. So I'll be around afterwards if you want to chat. Yeah, so we actually started an ambulatory withdrawal management clinic in Mercer County. So it operates a level 1 ASAM, so level 1 and level 2. So that we do home induction as well as on-site with monitoring. We don't do inpatient withdrawal management. What we found, though, is that many of the folks, our system in New Jersey was really geared toward people going inpatient for withdrawal management and induction, even though it wasn't really clinically necessary, especially for opiates. And so when we opened up our withdrawal management facility, working with folks, and we were working with alcohol, benzos, and opiates, we found that there was a lot of folks that we would have otherwise sent inpatient that we were now able to treat. But the state, we had advocated for this for years along with Dr. Panenti about being able to license behavioral health facilities to do home induction as well, because we felt there were a lot of folks that could tolerate it. I think the beautiful part, I could talk forever about withdrawal management and detox and MAT, but the beautiful part about it is, and it's kind of at the core thing of what we're talking about here, is if you can keep people in the community and while they're getting treatment, I think that's the best outcome, right, in terms of what we do. So withdrawal management, ambulatory withdrawal management, lets people, live their lives and go on living their chosen valued role while they're getting care. So we do offer that, but we refer out for outpatient. The other thing we do, which has been going on for a while in New Jersey, and all 21 counties offer it, is the Opioid Overdose Recovery Program, or ORP. So any hospital providers or folks in here may be aware of it. but ORP is a service that provides a bedside intervention to individuals who were reversed with Narcan from an opiate overdose, and it helps to do the bedside intervention with a peer specialist, and then works with them to link to community-based care, and they do that all right in the emergency departments.
So I'm actually quite excited by what you just mentioned. As a physician who works in primarily Burlington and Mercer counties, I had no idea we had a community detox program, so I'm not letting you leave here without more information on that. One of the big things I've dealt with, especially during COVID, is the rebound from inpatient psychiatric stays. People being discharged back in the community with loose follow-up or no follow-up, and then not being accepted back into that inpatient hospital. And I'm talking schizophrenics, manic bipolar, people who still have pressured speech. One person recently who was homicidal, inpatient admitted and then released, and still was like literally psychotic. Can we utilize, if they are like a little better than they were when they went in and they're no longer threatening to stab me, can I use EISS for that? Is that appropriate, or what other recourse do we have?
Absolutely. So one thing I'll mention that's new, and a lot of, again, hospital people here are very acutely familiar with the QIP, the Quality Improvement Project from New Jersey Medicaid, and one of a few of the measures are looking at the transition back into the community and their engagement with care. And so that's really incentivizing a lot of healthcare systems to partner with behavioral health care clinics, and how to make those connections meaningful in terms of folks being discharged and connecting back out into the community. Just to kind of validate what you're saying a little bit, I was looking at a few years ago when we were starting the CCBHC, what were our show rates for people for that initial admission appointment from an inpatient psychiatric facility, and the show rate was as low as 25 to 30%. And so one of the things, again, with the CCBHC model that we were able to pilot and work on, and we were doing this actually with Capitol Health, but we were going on the inpatient unit and doing admissions and transition plans on the inpatient unit to get people to come into the community. It's quite a daunting task to say, I've been in the hospital for 2 weeks or a week, I have schizophrenia and other kind of, psychotic disorders, and here's a card, and, you're going to go into the community and just go to some random building you've never been to and talk to people you've never talked to before, and, we wish you well. I mean, that's really what the model is. And so I guess bringing up QIP, there's some systemic changes, I think, that are really promoting this better, improved transition of care, kind of a concept. And then there's systems, like our CCBHCs and like our EISS programs that are there to be able to, receive those folks. And I think it's our job to kind of figure out how those things kind of connect and mesh. So I'd be happy to talk a little bit more about that. But yeah.
So, one of the questions before we go to the next question, with, it's so hard with masks to see who people actually are, but what about outreach, like community outreach for a patient who may be not stable at home? We didn't talk about that at all, but I know that's an option.
Yeah, for crisis.
Yeah.
Yeah. So, while we operate in the hospitals, every crisis, team throughout the state does outreach in the community at the individual's home as well. So the person does not need to present at the emergency department to receive a crisis intervention. So, we get calls, somebody who's on a train platform, or, somebody who's at the transit center in Camden County. So, we make mobile outreach to that individual. We do our assessment with them there. And if they need to be, screened further and assessed for inpatient care, we bring them back to the emergency department so they can be medically cleared and, take the next few steps. But being out in the community is huge. And I know we had another question, but 988 is coming out soon, and I'm sure many may be familiar with what 988 is, but it's the new national suicide hotline that was passed, federal legislation that passed 988, and it's supposed to replicate 911 in both simplicity and severity of the calls in response to suicide, individuals who are experiencing suicidal ideation. And so what we're going to see on the back end of that is some other legislation and some other funding to support increased mobile outreach to help meet people in the community, to provide some stabilization, even when folks are not in an immediate risk of harming themselves or somebody else, but to try to stabilize them, initiate services, and really connect with them where they are.
Great.
How do we find out about our EISS if we're not in this region? Like, I'm from Somerset County.
So the Division of Mental Health and Addiction Services, so DMHAS, has resources on there. They have links and information. But, I think one of the first, steps could be to just reach out with some of the behavioral health care facilities in Somerset County or Somerset County Department of Human Services. I think would probably be a good first place to start. And, there's lots of mental health board meetings that every county has, systems review committee meetings that are held that bring all these different partners together. Outside individuals are welcomed. So, I think either, using DMHAS's website or connecting with your county will be able to kind of help, plant you with all these other different community partners providing lots of different things.
Since so many of these folks wind up back in our offices, how do you communicate with us? How do we know what's happened? How do we know what the next plan is? I don't seem to get a ton of fan mail from the various behavioral health entities as far as what happened and what's going to happen next. So in what ways do you, assuming that they have a medical home, how do you communicate with us?
Okay, great question. So do you mind if I'm just talking?
Yeah. We're all comfortable.
All right. So two things. So again, as an extension of our certified community behavioral health clinic, one of the focuses on that was care coordination and collaboration and data exchange. So Oaks is pretty unique in what we're doing in this way, but what we are doing is we're working with the Health Information Exchange that's operated through the Camden Coalition and the Trenton Health Team, and we're actually going to be, hopefully, as long as we can get through these HIPAA 42 CFR Part 2 sorts of things, being able to do bi-directional data exchange with the Health Information Exchange platforms, which means that we'll be exchanging information that's viewable by hospital partners and primary care partners in the community to be able to view enrollment information or medication information and so on. So there's a lot of different use cases that we're using for that, but that's one, that's certainly one option. The other option on the technological side, there's a platform called Quartet that some of you, I don't know if anyone in here is familiar with Quartet by any chance? All right, got a few folks. So Quartet's a newer platform that connects primary care and specialty providers with behavioral health clinics. So it's both a referral platform as well as a data exchange platform. So we've been using Quartet for about 2 years. It's owned or in partnership with Horizon Blue Cross Blue Shield, but referrals and information can be made for individuals at your clinic with any type of insurance. So the idea behind Quartet, you're seeing somebody in your practice, you're identifying they have a behavioral health need, you click a button, I don't know how it works on the provider end necessarily, but you click some kind of magic thing, it sends a referral through to Quartet. Quartet then sends that information out to behavioral health providers that are in their network throughout the state. And then once we receive that referral and we admit the individual, then we provide feedback and information back to Quartet, who pushes that back to the doctor. So it might be things like PHQ-9 information, medication information, treatment plan goals, general things like that, just to kind of give a snapshot. The other last thing I'll say too is just, again, building those partnerships. So I know one of the things we're trying to do, we're always trying to do, is build relationships with our primary care partners. We have nurses, nurse care managers, and care managers that are in the field, and they're usually very good resources just to be exchanging information in terms of what's going on with care, what their medications might be, so on and so forth. So it's that relationship building piece as well.
Dr. Van Zouder gets the last question, and then I'm going to thank
Just a
everyone.
comment. So we actively use Quartet in our practice. We just find it very difficult for them to communicate back with us with any substance. So we'll get back patient stable, and that's it. So if you're going to use them, just make sure you stay on them to get useful information, not just 2 lines that say patient stable, patient stable.
Agreed. Lot of workflows on both ends with Quartet to make it functional in the way you want it to be functional. So yeah, the feedback is important.
So I want to thank you all for your attention, but I really want to thank the panel. John Verney, who is the former director, the state director for the Screening Center from the Division of Mental Health and Addiction Services, who was supposed to be with us today, had another issue come up and couldn't join us. But John orchestrated this and I think really hit it out of the park. John insisted that Mike be a part of this due to his depth of knowledge, and I think, Mike, you totally knocked that out of the park. Walt, who introduced himself very modestly, is a Des Moines graduate and a Costin Scholar, and does more for community mental health in the southern region than perhaps anyone else I know. And Susan, who also modestly introduced herself, is heavily relied on by the Department of Health. For those of you who follow the whole Andover mess from the COVID crisis in the news, Susan and her team have been pulled by the Department of Health to go in and do a deep dive into Andover, and are making suggestions and evaluating patient by patient, and are involved in that whole investigation. And they're also called quietly into other facilities, not just by the facilities, but by the state. And so you really had a wonderful heavy hitter team here today. And the reason I'm pulling that out is not only so that you know the quality of who presented to you today, but each one of these people gave up very, very busy schedules to make time to be here for all of you, and I hope you really appreciated it. Thank you, everyone.